I'm Dr. Nagla Abderrazek, lecturer of radiology in Cairo University, and I'm the Secretary General of the Scientific Society of Diagnostic Radiology. I will talk about virtual bronchoscopy. Increasing use of volumetric scanning has led to the rapid acquisition of cross-sectional data encompassing the entire thorax and manipulation of this information using innovative computer technology have led to multiplanar and 3D reconstruction as well as improved conventional cross-sectional imaging. Virtual endoscopy describes several techniques to create visualization from 3D medical image scans similar to those produced by the current minimally invasive endoscopic procedure. As you can see, this image we get from CT. It's similar to what's obtained by fiber optic bronchoscopy. Virtual bronchoscopy, by definition, is a type of 3D reconstruction in which the observation point is placed within the airway to produce endoscopic-like display without the use of endoscope. Here we have an external rendering, 3D rendering of the airway, and we have the corresponding endoscopic-like image can be obtained at endobronchial checkpoints, or we can navigate through the reformatted 3D map. The basic steps for creating virtual endoscopy include image acquisition. By image acquisition, we mean how to take the image, or how to examine the patient from the start. Image processing, and it includes two steps, segmentation and fly-through. Image analysis, how to analyze the virtual endoscopy image and image display. Maximum resolution during virtual bronchoscopy was obtained with the smallest beam collimation, slowest table speed, and maximum degree of slice overlap. It was noted that with using 2 mm provides the best results. Here we have a diagram showing what we can obtain by virtual endoscopy when using 5 mm without overlap, 5 mm with overlap, and 2 mm with overlap. What is stained in red is will be viewed in virtual bronchoscopy by maximum resolution, and the yellow is at a lower resolution. As you can see, with using the 2 mm section with overlap, we can navigate down to the peripheral and very up to down to the 6th order bronchial bifurcation. Image processing, including two steps in the technique, as I said before, the segmentation and the fly-through. Segmentation, by definition, is the method by which the user can generate a stereoscopic image of the inner wall of any 3D of any cavitary organ from the original axial 3D images. That's to say, we can make a 3D of the inner wall. It's not an external rendering, it is an internal rendering of a cavitary or hollow viscous like the stomach, like the small intestine, large intestine, after room air insufflation, or natively the air-containing structures like tracheobronchial tree, oral paranasal sinuses, the inner ear. Thresholding is the method that we do this by through segmentation. By thresholding, we can make maximum appearance within a threshold range, a specified threshold range. How can we use this? By it's embedded in the program. A more sophisticated method being developed with the use of advanced processing techniques allow reconstruction of all connected voxels within the airway. The result of regional extraction or segmentation is a 3D reconstruction representing the tracheobronchial tree. By fly-through, we can navigate through the already reconstructed 3D image. As you can see in our image, here we have a 3D external rendering of the airway and the corresponding endoscopic image showing the polypoid mass obstructing the right main bronchus. If we look at the external 3D image, you can see the bronchus amputated. Okay? So by using the segmentation and fly-through, we can examine the airway externally and internally. Okay, another function in the program that we can look in anti-flexed and retroflexed view. That's to say, we can examine from the trachea to the bronchi, and retroflexed view, we can examine from the bronchus to the trachea. So if we have an obstruction here, we can examine on the other direction. By image display, we mean the viewing methods, either computer print or video print or CD or ordinary films. So we have a simplified approach. First, we do spiral CT or multi-slice CT, and we take dedicated thin slices for virtual bronchoscopy. These images transfer to the workstation, and then we generate a volumetric study from the axial images. Then we go for segmentation, saving the results, and we fly through and navigate through the segmented matrix. Then we either have still images or to the color printer, or recording on video tabs or CDs. To appreciate the normal tracheobronchial anatomy and pathology on simulated endoscopic image, it is very important to familiarize oneself with the appearance of the normal tracheobronchial anatomy on conventional bronchoscopy. Okay, we have the trachea, which is 4 centimeter in the newborn and 11 to 13 centimeter in adults. The trachea then bifurcate into right main bronchus and left main bronchus at the level of the carina. Then we have 10 segments in each lung, where the right lung divides into upper lobe, middle lobe, and lower lobe. The bronchus divides into upper lobe bronchus and bronchus intermedius. Then the bronchus intermedius gives rise to the segments of the middle lobe and the segments of the lower lobe. We call the upper lobe apical, posterior, and anterior segments, the middle lobe lateral and medial segments, and then the lower lobe superior. It is recently in the literature corrected as superior because we have apical in the upper lobe, so it's preferable to call it superior, anterior, medial, lateral, and posterior basal. And then coming to the left side, we have upper lobe and lower lobes. Upper lobe divides into apico-posterior, anterior, and the branch to the lingula, which divides then into superior and inferior. Then we have the basal segments and the superior segment of the left lower lobe. So on the left side, we have only 8 segments. We do not have medial segments, medial basal segments, and we do not have, the upper lobe is only 2 segments, apico-posterior is 1 segment. This is how the endoscopic anatomy looks like. We have different appreciation rather than the axial CT, like when you are directed downwards, you are going to the carina, below the level of the carina, then you are directed towards the right main bronchus. Coming to the right main bronchus, what's anterior is upper lobe, what's posterior is bronchus intermedius, and so on. The appearance of each bronchus end on like rounded or triangular or elliptical, you have to appreciate the anatomy this way. It's slightly different than the axial anatomy. Then how to analyze the images of virtual bronchoscopy? We look for the presence of endoluminal mass, extraluminal compression. We look for bronchial stenosis, bronchial obstruction, and very important to look distal to the obstruction, the status of the bronchial tree distal to the obstruction. So the images again are interpreted for endoluminal mass, extraluminal compression, bronchial stenosis, bronchial obstruction, and the status of the bronchial tree distal to the obstruction. We have potential applications for virtual bronchoscopy. We can first start with the upper airway diagnosis. One application of this new perspective have been in the evaluation and management of patients with upper airway or tracheal disease. We have here a polyp posterior to the vocal cords, and this is the level of the vocal cords while approximated together. This is a case of post-tracheostomy narrowing. We can see in the sagittal rim formatted image the level of narrowing. On the 3D images, we can examine the stenotic segment. We can measure or take the length when it starts, when it ends, the length, the diameter of the stenotic segment, and this also helps the interventional procedures that the patient will go on. This is the maximum transverse diameter at the level of narrowing, and here is the diameter distal or proximal to the obstruction. This is a case of thyroid carcinoma. As you can see on the axial images, a solid mass involving the right thyroid lobe, and there is a polypoid invasion into the trachea. On doing fiber optic bronchoscopies, the further introduction of the endoscope were impeded by the obstruction, and they asked for virtual bronchoscopy. As you can see here, the external rendering showing a filling defect on the external 3D of the trachea, and here is at the narrowed lumen of the trachea at the point of maximum narrowing, the polypoid lesion projecting inside the lumen of the trachea. And here is distal to the obstruction. Virtual bronchoscopy was superior to fiber optic endoscopy in examining the patient distal to the obstruction. Yes, coming to the lower airway diagnosis, preliminary experience with virtual bronchoscopy focused on the feasibility of detecting major central lower airway abnormalities, like the most important is neoplastic lesions, and of less importance, the bronchiectasis. Here we have a stenotic lesion obstructing the right main bronchus, and there is the corresponding fiber optic endoscopy image and virtual endoscopy showing the polypoid mass. Here we have another case showing polypoid lesion attenuating the right main bronchus, and this is a corresponding fiber optic endoscopy image. This is an example of endoluminal mass. Here we have a case of, as you can see, the right hemithorax is almost obliterated by pneumolytic changes, fluid and soft tissue, but there is no definite mass lesion seen. But we can appreciate that the right main bronchus is not shown clearly in the image, maybe attenuated or something like this. By virtual endoscopy, we can see that the right main bronchus is amputated, and there is an endoluminal mass obstructing its lumen just distal to the carina. So we have two important points here. Virtual endoscopy added the presence of a mass, and it transfers the patient to a higher stage of malignancy, because having a lesion that is very close to the carina, less than 1 centimeter beyond the carina, is stage 4. Here is another case showing irregular mass lesion attenuating the right main bronchus with associated pleural effusion and subcarinal lymph nodes, and distal pneumolytic changes or distal obstructive pneumonitis. Virtual endoscopy showing the extraluminal compression by virtue of the enlarged lymph nodes and the presence of right upper lobe obstruction. And these are the corresponding fiber optic endoscopy images. This is another case showing pneumonitis of the left lingula and anterior segment of the right lower lobe. We can see also the left main bronchus is attenuated and fairly seen. Here is a corresponding virtual endoscopy image showing polypoid mass obstructing the left main bronchus, which is seen amputated in the 3D map. And here we have, we can measure the length between the obstruction and the distal aeration. This is a male patient, 15 years old, coming complaining of dyspnea and dry cough. Anybody want to share what's seen in the plain X-ray? Dr. Mohammed. Yes, exactly. There is loss of volume on the right hemithorax, and there is a homogeneous opacity, indistinct from the right cardiac border and the diaphragmatic cupula. So we are suspecting collapse, maybe middle lobe collapse. Here is the axial CT image showing collapsed middle lobe. Okay, that's what we gain from the CT and the X-ray. Adding the information of virtual endoscopy, we can clearly see a large mass obstructing the bronchus intermedius at the opening to the middle lobe bronchus. And this is a corresponding fiber optic endoscopy confirming the results. It was a fibrosarcoma of the bronchus. The patient had underwent laser coagulation, and this is the appearance of the airway after laser reduction. And this is the fiber optic endoscopy at the attempt of laser. Then the patient has done a sleeve resection, and this is the airway after the sleeve resection. They removed the bronchus with its tumor, and then sutures are taken through the upper and lower lobe, and this is a clear surgical margin. And patient is on follow-up for 6 years now. Also, it was found that the combination of endoluminal and extraluminal 3D construction helpful in characterizing bronchiectasis, producing bronchogram-like quality images. Here like this, we can see the opening of dilated bronchi, and then by adding the information of the external rendering, the hybrid presentation, we can show the saccular dilatation of the bronchi, producing what's called bronchogram-like quality image. Like here, we have a cavitary lesion connected to the bronchi. Also adding the information, combining the information of conventional CT criteria and the relation of the tumor to the tracheobronchial treat, was found that among our patients, many patients have transferred into higher grades of malignancy. Also, it was helpful in providing a map for transbronchial biopsy. This image shows a transparent presentation of the airway, and we can see here a pulmonary vessel. So on doing transbronchial biopsy, we can avoid the area of the pulmonary vessel. Increasing experience with laser photocoagulation, brachytherapy, and endobronchial cryotherapy, placement of tracheobronchial stents has affirmed the importance of accurate preoperative characterization of airway abnormality, measurements of stenosis to optimize stent fitting. Like here, we can measure the area of narrowing, the length, the width to optimize for stent fitting. Here is a case of bronchogenic carcinoma involving the right main bronchus. After this patient was non-operable, and he underwent electrocautery. This is the mass before electrocautery, and this is the appearance of the airway after electrocautery. Likewise, the indications of flexible bronchoscopy is especially in young children restricted not only because of the invasive procedure but also because of the inevitable sedation with its risk factors. In these instances, virtual bronchoscopy can be calculated with high quality CT study in children. The most important diagnostic conditions found by virtual bronchoscopy is the tracheobronchial fistula and tracheal atresia. We all know that we have 5 types of tracheobronchial fistula. Here is a virtual bronchoscopy, the fiber optic bronchoscopy showing the fistula tract. Virtual bronchoscopy is a 3D reconstruction used to locate the site of the fistula and assess the length of the gap between the fistula and the upper or the lower esophageal pouch, like here. Also, in cases of stenosis and congenital webs, we can measure the length of stenosis and the location of the web. Coming to foregut cysts, bronchogenic cysts develop as a result of abnormal budding of the tracheobronchial tree, and cysts usually single or large. Tracheobronchial tumor like recurrent papillary papillomatosis, like here. The papillae will be clearly seen in the coronal and virtual endoscopy images. Okay, very important application is the foreign body inhalation in the airway. Normally, the ordinary radiologic evaluation was chest and neck radiographs, and it was advisable to use barium to localize the non-opaque esophageal foreign body, but it complicates the subsequent attempt of endoscopic removal. It can aspirate during the study. It delays the endoscopic procedure for 6 hours at least. On using CT, we may be useful to assess with standard radiographic studies when failed to demonstrate the foreign body. Studies found that the foreign body was detected by both CT virtual bronchoscopy and rigid bronchoscopy with no discordance between the two modalities, so they suggested that CT virtual bronchoscopy should be the first imaging modality in children who are suspected of foreign body inhalation to obviate the risk of general anesthesia if the study is negative. Here we have a foreign body, and this is the corresponding virtual endoscopy showing this tricky artifact indicating the location of the foreign body. We have a female patient, 1 month old, with dyspnea and chest problem, diminished airway. We have here the opaque left hemithorax, and this is a corresponding CT. This is the coronal image showing something in the left main bronchus, and this is the virtual endoscopy showing the foreign body in the opening to the left main bronchus. Another case, 2 days, presented with difficult swallowing, drooping of saliva, and difficult breathing. We have here what we have. We have a trachea and dilated esophagus. So what we are suspecting? We are suspecting tracheoesophageal fistula. Here is a coronal plane showing the fistula tract between the trachea and the esophagus. And this is the virtual endoscopy showing the opening, the tracheoesophageal opening. Fistula tract, I mean. A male patient, 6 years old, presented with choking attack and history of foreign body inhalation. Rigid bronchoscopy was done, and it detected a foreign body already in the right main bronchus, but failed to extract it. And they asked for virtual bronchoscopy to accurately localize the foreign body location. Here we have the opaque foreign body, and this is by axial CT. It do not add any information more than the X-ray, but on using virtual bronchoscopy, we can locate the lesion inside the opening of the right, the bronchus intermedius towards the upper lobe. A case of 9 months baby with pneumonia. Another foreign body impacted in the right main bronchus. Female patient, 1 year old with history of foreign body. Okay, we have a foreign body, but on doing virtual endoscopy, it added that the patient has what's called recurrent papillary tumor of the trachea. We have multiple polyps was seen. And this is the foreign body. This is a case of generalized lymphadenopathy on the mediastinal window showing the lymph nodes, and on virtual bronchoscopy you can see the mass effect or the external indentation on the airway by the enlarged lymph nodes. Last case is a 1 year old presented with dyspnea and wheezes. We have here a large soft tissue shadow on the left side of the mediastinum. This is the bronchogenic cyst on CT, and here is the external effect on the airway by virtue of the cyst. Another case with wheezes. It was a paratracheal tumor, paratracheal cyst, and causing external indentation on the airway. Okay. Also, virtual bronchoscopy can be applied for educational and research applications, graphic rendering of anatomy, bronchoscopic training and pre-bronchoscopy planning, preparation for current patient procedures, and contribution to medical literature. Advantage of virtual bronchoscopy include it being non-invasive, stenosis obstruction and endoscopically inaccessible areas are no obstacle to it. Extraluminal compression is always available, providing guidance for ensuring intervention. Though distortion-free measurements can be obtained, it can be performed under mild sedation in children, can improve conventional endoscopy techniques by providing orientation relative to the patient or relative to the immediate surrounding anatomy, provide more information, help to design accurate stent before intervention. So what are the limitations? It's a static examination. It's not as sensitive as true endoscopy in detecting the cause of airway obstruction when it is a dynamic cause like tracheomalacia. 3D and CT softwares relies on the presence of air, so mucus plugs and secretion inside the lumen can make airway appear suspiciously stenosed. Provide no color or texture of the airway mucosa because it's not represented in the CT data. Flexible bronchoscopy in the hands of experienced pneumatologists will remain the gold standard. However, along with the rapid advantage in computing speed and further expansion of multi-slice technology, virtual bronchoscopy will find its place in the daily routine and will continue to exist as one of the many presentation forms from which to choose for chest imaging. Thank you.